got my sunglasses on because, whoa, Joseph, man, there's such a glare on that big knob of yours. What the heck? In case you think he looks different, he does. He shaved off his hair. But anyway, he does that every once in a while. Hey, welcome, OT Help Desk. We are looking at another series of YouTube videos, and today we're gonna talk about the spinal cord and kind of break it down a little bit so we get an idea of some of the things that might help you when it comes to concentrating on preparing for both clinical and reasoning type questions. So I forgot again. Okay, I'm Big J.
I'm Little J.
There we go. Seems like I do that all the time.
I wasn't gonna say anything.
Yeah, all right. Yeah, right. So, all right. So let's think about this. Let's think about spinal cord and our experience, okay, in the OT Help Desk with the common types of questions that we hear. And I say what we'll do is we'll start with the levels of spinal cord. Start at C4 and kind of work our way down and highlight some of those areas. And if you look above us, they'll be up there. So, so you can kind of, follow along with us. But a little bit more of a clinical reasoning perspective of how we do this, because a lot of times everybody memorizes things and I'm not a memorizer. So what I like to do is organize it more from a reasoning perspective. Okay, so here's how I look at it, and I'll use you to help me because you're like my dictionary. Yeah.
Right.
All right. Okay. So right out of the gate, let's think about a C4, which is that a quadriplegia, tetraplegia? What is it?
Tetraplegia or quadriplegia, however you want to say it, but all four of their extremities are not going to be innervated.
All right. Okay. So in a C4, okay, let's call them our big guns. What are our big guns in a C4 that we should really be thinking about?
So one of the first things we're going to be thinking about is initially we have to think about the context, right? So if they're in an acute care setting, they might...
There we go.
Exactly. If they're in an acute care setting, they might be initially dependent on the vent for breathing.
Remember that. Initially dependent. And why? Why are they initially dependent?
So it's a little bit tricky because at this stage, they are going to have innervation in the diaphragm, which we know is the main muscle of breathing, of inspiration, but it's going to be weakened initially. So that's why as you progress through the process, or they're typically at this level able to progress breathing on their own versus being on the vent, but initially they might be ventilator dependent for breathing.
So they might not be dependent later. Okay, in other words, they might not need a ventilator, and as a C4, there's still a lot of things that a C4 can do. All right, so we got the ventilator, and they're gonna most likely have a trach that'll be managed. And then from there in a C4, my favorite, right? My favorite is that we are blessed with the cranial nerve,
yep,
good old cranial nerves.
Yep.
So, and the cranial nerves, cranial nerve 11.
Cranial
what
nerve
is
11,
it? Smarty.
Accessory nerve.
The accessory nerve, and the accessory nerve innervates the
sternocleidomastoid, and it's also going to innervate the trapezius muscle.
Got it. So we need to remember that, right? Sternocleidomastoid, sternocleidomastoid, and trapezius. So what's that going to do for us?
Well, the sternocleidomastoid is going to allow for head movement, for rotation of the head, and so that's going to be really big when we're thinking about things like wheelchair mobility, for example, because they might be able to maneuver their power wheelchair in a way that they wouldn't traditionally with their extremities, but they can maneuver it with head control or sip and puff control, maybe chin control. So they can use their intact abilities to maneuver their wheelchair and then also complete pressure relief in the wheelchair if they've got a tilt and space chair.
So I got this little way of remembering for how we work through the process here. First comes head, then neck, then trunk, then hips, then knees, and then feet, right? Not hard, okay? But in this particular case with the C4, let's talk about mobility in terms of a wheelchair. What kind of wheelchair are they going to use?
Definitely going to need a power wheelchair,
okay.
And a tilt and space option is going to be good for them. Why a tilt and space? Well, one of the things that a tilt and space is going to be good for is pressure relief. So if they have a tilt and space wheelchair, they can use their head controls theoretically to be able to independently do their pressure relief when they're in the wheelchair. Even without having the upper extremity function, they can do it in that way. Another thing,
what about the trunk? What about the trunk?
Exactly, that's what I was going to say.
Okay.
The good thing for a tilt and space chair too is that you can use the tilt feature and help use gravity to your advantage there. And it's going to reduce the risk of them tipping forward out of the chair during mobility, because we know that they're not going to have the volitional trunk support because the trunk muscles are not going to be innervated. And so during their wheelchair propulsion, if you have them slightly tilt the chair, then that is going to decrease the risk of them tipping out of the chair, because you're using gravity to your advantage, and gravity is almost kind of pulling them back in the chair in a certain sense.
So would it be safe to assume that ADLs are pretty much dependent?
Yeah, you're going to be, because you don't have innervation of the upper or lower extremities, even though you have the head control, your ADLs are pretty much going to be, you're pretty much.
So somebody can feed you, right?
Right.
Somebody can help you get dressed, and when they feed you, you can chew, right?
Right. You should be able to chew and swallow because of those good old cranial nerves.
Good old cranial nerves, baby. Yeah. You're going to be able to move your face. You're going to be able to do everything because of the cranial nerves, right?
Right.
All right. So that really functionally helps us understand, that C4.
Right. And you can do certain leisure activities too, like you can use something like a typing stick or a mouth stick.
There you go.
Environmental control.
And they're IADLs. So IADLs, we've got leisure. Okay. And give me an example. I'm sorry, I interrupt you.
No, I was just saying you could use something like an environmental control unit, and you could use the typing stick, or you could use the voice control to activate those. So, different ways to do those, even though you're going to be pretty much total assist for ADLs.
Will you use sip and puff?
You could use sip and puff for wheelchair mobility.
Oh, wheelchair mobility. I guess you're not going to use that to help you read with a dress and a stick. No, all right, okay, good. All right. So we got C4. I think we kind of managed. And again, we're building here. We're building right down C5. C5 gets exciting. So what's wonderful about C5?
You got the deltoids.
The deltoids, and
you got the biceps.
Deltoids at C5.
Mm-hmm.
Wow.
Deltoids.
Deltoids. Yeah, we're gonna have shoulder flexion, and we'll also have some abduction, right?
Mm-hmm. And you got some elbow extension. I'm sorry, not elbow extension.
Ooh.
You got elbow flexion.
Elbow flexion.
Yep, elbow flexion.
And with that, now work your way down. So we got delts, we got elbow flexion, and then brachioradialis.
And the brachialis.
And the brachialis. Oh, perfect. Because now we've got supination. So we can actually supinate, okay? And at the same time, watch this. My brachioradialis inserts here, comes down here. I can put a universal cuff on, and boom, I can bring food to my mouth.
Right, and you can supinate because the bicep helps with supination.
Right, so that's where you have this movement, okay, that you train. You end up having to go back and train through with a C5, so that they're coordinating the movements, okay? But we got a lot that we can use here. C5's tricky. What's one of the things that helps the C5, and tell me why? Because it's the first thing I think of.
Universal cup.
Universal cup. Well, no, that's for eating. No, I want to talk about what I'm going to use for up here to help them.
So you could potentially use a mobile arm support.
So C5 mobile arm support.
So even though you've got the active shoulder flexion, initially their muscular endurance is going to be really poor, and so you can use the mobile arm support to help strengthen their muscles while also compensating for their impaired muscular endurance initially. So even though they've got the shoulder flexion, you can still use the mobile arm support to kind of help compensate and strengthen their muscles.
Nice. I like that. All right, now let's move on to what kinds of things in C5 could a person be able to do independently, and what things will they be dependent for?
So they're going to be dependent, of course, for a lot of their lower body ADLs, but they should be able to assist with their upper body ADLs. So they should be independent, after setup of things like grooming, oral hygiene, self-feeding.
We still need setup, huh?
Yeah, probably need setup at that point, but
not independent.
But they should be able to do those without assistance with different things like the universal cuffs, for example, can be something that can be really useful within both of those. Maybe you have them in some type of orthotic that maintains them in wrist extension with the universal cuff applied, so that then they'll then be able to bring the utensils to their mouth during self-feeding, for example.
So, head, neck, trunk. What about mobility in a C5?
And a C5, you're still going to be pretty much total assistance for transfers at that point. You should be able to maneuver your power wheelchair, and you can actually maneuver a manual wheelchair for really short distances if you have the specialized pegs where you don't have to have the hand control to do it there. But for the most part,
commonly seen.
Yeah, for the most part, they're going to have a power wheelchair.
Yeah, because I like to draw the distinction between C5 and C6 and suggesting that C6 could be independent, okay, with getting into a wheelchair, right?
So
we're going to talk about that
moving
now.
on to C6 now.
We're going to move on to C6.
All right.
So C6, the infamous, the amazing tenodesis, right?
That's right.
That's right. Tenodesis. So now we've got tenodesis at C6, but I jumped ahead. So let's go back and talk about the muscles. All right. So
the big one that allows us for tenodesis at C6 is that you can extend your wrist.
Yes.
You've got wrist extension at C6.
right. What else? Anything else that we should be thinking about? Because we still have the biceps. We still have the deltoids. Okay, the brachioradialis and that group. And now we have the wrist.
And you've also got the shoulder depressors.
Well, they're big time,
right?
Because that's going to be the shoulder depressors. Okay, what helps us with shoulder depressors?
You've got the latissimus dorsi, I think, in terms of the muscle there.
Okay, so those guys are going to help us a lot with our transfer, and we'll talk about that. All right, so as we go down, let's at least begin with the head and talk about the head, neck, and the arms, and talk about what a person's going to be able to do from more from an ADL perspective.
Sure.
Okay.
So from an ADL perspective, it's going to be similar to the C5 level, but you're going to be able to add on a few more things here. So again, you're probably going to need things like the universal cuff for self-feeding, some different forms of equipment that way, but you're going to probably be able to manipulate and maneuver your lower extremities a little bit easier here, because you can use something like a thigh strap, for example, for lower body dressing. And what you can do with that is you can have a caregiver apply it to their thigh, and then you can use your wrist extension paired with elbow flexion to help bring your legs up to yourself to make a frog sitting position, if you've ever heard of that, so that you can help to manage your lower extremities a little more during your lower body ADLs. You're still going to need a good bit of assistance with that.
Okay, so are you saying that they're not independent in ADLs?
They're not going to be independent still at this level. They're still going to need some assistance for their lower body ADLs.
Some assistance.
They should be independent with upper body ADLs, and they can assist with their lower body ADLs, but they're not going to be independent still.
The big question now comes up. Okay, are you going to be able to transfer independently? Can you transfer independently with a C6?
On level surfaces, you should be able to.
All right, so here's the one that you hear a lot about. They'll ask, or you have to think about the fact that how are you going to position yourself? And now we got to remember the muscles, okay, that are involved. But how are you going to position yourself during a transfer with a C6? Okay.
All right.
So the first thing that we know we have to do is we have to position, right?
Right.
Okay. So ultimately, where are the arms going to be in this case? And let's make sure that we understand what's going to happen, because you can tenodese, right?
You can.
Okay. Do you tenodese? Does it look like this when you transfer, or does it look like this? What do we do?
So what we want to do, well, let's start from the top here.
Let's start.
So we want to have the shoulders externally rotated here, because that's going to help us lock out our elbows, because we know that we're not going to have elbow extension here, so we're not going to be able to actively push using our elbows, but what we can do is we can compensate for that, and we can use the shoulder depressors instead.
And you also have to
externally rotate.
Externally rotate.
So what I'm going to do here is I'm going to externally rotate at my shoulder.
So external rotation.
And I'm going to lock out my elbows.
See, it's not elbow extension, right? It's the external rotators, okay? And then you got the biceps. Okay, you still have the brachioradialis here. Okay, but look at where the hands are. Okay, the hands aren't forward because you would fall right on top of them, right? So the hands are out to the side, and you are using this whole process of external rotation now with the shoulder and the scapula, because you have it, and the deltoids, all those guys to actually support you. So you're minus the triceps, and it's a really nice process when you learn it. okay, to be able to do it. And then you can transfer effectively, right?
Sure.
So how does that work anyway?
And so you see that my hands are still in the tenodesis grasp. You want to preserve that during the transfer, but I'm essentially using the palms of my hands there.
Okay, and so what happens? How does it work when you go to transfer?
So basically you get your momentum. You want to make sure that your feet are in a good position.
Now, are your legs where they should be, or should your legs be your leg be out a little bit?
It should be out a little bit. They should be underneath you, but not tucked too far underneath you.
Because you'll fall forward. Right.
So what you can do to position that yourself at this level is you can take, you've got wrist extension, you've got elbow flexion, so you can use those to help position your legs here. So what I would do is I would position my legs directly underneath me here.
Yep.
Again, I'm making sure that I'm externally rotated here, that I'm locked into extension. Even though I don't have active elbow extension, I can still compensate and lock into this position. My wrists are extended. I'm preserving my tenodesis grasp while I'm doing the transfer here.
So this is physics. And if it's all done in one shot, okay, show us.
Exactly,
Show us.
you use your momentum. So you can see I'm in this position here, and I'm going to use my depressors to help lift my bottom here, because I know I'm not going to be able to do that with the triceps at this level. So you use your momentum, and you just kind of swing yourself.
No chair, Joseph, no chair. Get back up, get back up. Oh my gosh. It happens. No, I didn't. I never got the chair. All right. Anyway, but you saw the mechanic of how fast it happens, right? So it really has to be practice, okay? But with the C6, the key to remember is how that works with external rotation and the locking using the biceps, not the triceps.
Right.
So good job, good job. Now, is there a certain type of a chair now? Because we know C4, we know C5, certain types of chairs because of the ability to actually pressure, shift for pressure release. Okay, what does a C6 do in terms of pressure relief once they get into a chair?
So again, they should be able to kind of use their biceps to be able to, they can even lean and use their biceps to help pressure relief, but in likelihood, it's probably still gonna be more of a power wheelchair situation, because then with the tilt and space pressure relief option, and then also with some type of a specialized wheelchair cushion, that's gonna be the best option for their pressure relief.
Nice. Okay, so we got C6, and now we're going to move on. And of course, as we move on, we pick up more and more. So what do we pick up with the C7?
So the big thing with C7 is now you got the triceps, so you can extend your elbows.
That's right. Okay, so triceps are the big gun there. Do we pick up anything at the hand? Okay,
so
with
you're
the
going to
C7?
have wrist flexion at C7.
Okay, so we had wrist extension at C6. Now we're going to pick up wrist flexion.
Yeah, and that's
but what's
help.
missing?
We're still missing the finger flexion. We've got digital extension.
Digital extension, but no flexion.
But no flexion. We're still missing finger flexion at C7.
So now transfers get a lot different.
They do. They become much easier because then you can use your triceps to help progress yourself across the board.
Yep. Okay, so let's go back. So we understand the difference in the muscles. Okay, triceps, and we have some of the wrist flexors involved now. So how does this stack up in terms of, does it change mobility?
It does change mobility, yeah. It's going to make sliding more transfers easier in terms of a C7. You can progress to more unlevel surfaces like a commode chair or a tub transfer bench, for example, that were going to be a little bit more difficult at C6, because we talked about at C6 with your transfers, they're going to be more independent if they're going to level even surfaces. But when you progress to C7 with the added strength of the triceps, we can progress to those more unlevel surfaces.
So the thing is, obviously, we're picking up more muscle strength as we go along.
Right.
Okay, but where's that break in independence in ADLs? Is it in this group, C7?
So at C7 they can definitely become more independent with their ADLs. They still might require a little assistance for the lower body ADLs, but they are progressing more towards independence. So they have the ability to be independent. They might require a little bit of assistance, but at C7 and progressing forward, they do have the ability, the potential is there to be independent with their lower body ADLs as well as their upper body ADLs.
All right, cool. So, and is there anything about ADLs, okay, that we should talk about with the C7?
I think that, a lot of
Where's that universal cuff a minute.
The universal cuff is probably still going to be something that you're going to use.
Why? Because we don't
Well, because we still don't have the digital flexors.
Digital flexors.
But what you could do is you could use a tenodesis splint or an orthotic to help augment their tenodesis grasp, and then that would allow you to use up some different types of adaptive equipment. So that would allow you to grasp something like a long-handled sponge, or you know, different types of adaptive equipment that you could use for your lower body ADLs.
Okay, all right. All right, so there's the next step from a C7, you know, you roll, and in fact, I know even in Pedretti it goes C7 through T1, okay, and you know, with a C7 moving to a C8, what's going to be our differences there, right?
So we've got digital flexion.
Now we got digital flexion, and that's a game changer.
This is a game changer. So you should be independent with all of your lower body ADLs at this point. I mean, there are some individuals who might need, you know, some assistance
depending on weight or
depending on other
size,
factors,
stuff like that.
But you have the potential to be absolutely independent with your ADLs because you can use your fingers to grasp and volitionally, and that's going to make a huge difference there. So you can use your upper extremities to fully support and manage your lower extremities during your ADLs.
Will this person at that level need a you know, in terms of wheelchairs, will they need something powered, or can they operate a wheelchair on their own? When are people going to be able to operate wheelchairs?
So they should be able to operate a manual wheelchair on their own at this point.
So at C8. So we're still suggesting at C6 and C7 that it might be difficult to do it. There are some that can, okay, but C8's pretty much independent in wheelchair, and you're not having to have a, you know, an electric, you know, type situation.
Well,
some will, but
in C7 too, I would say they're more independent with the manual wheelchair.
Okay, there we go.
They can use their triceps.
There you go.
The propulsion.
There you go. So
they still might,
C7.
and they might need a power wheelchair for long distances if that's an option.
Right.
But for definitely, you know, short household distances and short community distances, they can propel a manual wheelchair.
All right, good thought. So
now at C7, they would still need the specialized, you know, the wheelchair pegs, because they're not going to be able to grasp the wheels. I do want to mention that.
Nice. All right, so the last thing that I want to mention is this crossover, because it seems like right at C8 to T1, okay, you begin this whole concept of the person's going to be totally independent in ADLs and mobility, okay? But, you know, again, that digital flexion right before there, you know, the wrist flexion, okay, those things are keys, you know, to that. So for me, that's how I think about it, knowing that when I get to T1, really, it's fast sailing when you're working with an individual suffering a spinal cord injury. In that level, the higher the T, the less trunk, you know, stability you're going to have, right? And so you'll fall over, all right, if you're not careful. But they become very independent, and they use the rest of the upper body musculature to support what they're doing. So here, listen, we've spent a lot of time going down through each one of those, and you know, you've seen the summary above our heads as we're doing it here. Some things to think about. We spend a great deal of time at OT Help Desk with, of course, we provide videos for you to learn this information that we just talked about. Okay, but a lot about us pertains more to clinical reasoning and actually taking this information that we discussed here to a higher level. So, and a higher level means that we want an individual to be able to think through a clinical situation and be able to respond using these concepts that we talked about today. So we spend time in our open sessions where we review questions and students practice there, along with we build concepts in what we refer to as our topic sessions. So consider, you know, OT Help Desk as a place to come where we cover everything that you need to know. So we're happy that we had this opportunity to be here. Joseph's got to go to the hospital now because he hurt himself falling off the couch. But we we hope that you, what do we tell everybody?
Like and subscribe.
Like and subscribe. Please do that. And we're thankful to be here, and we're thankful that you've had the opportunity to share that with us. So we'll see you later on. Bye-bye.